All right, so we need to begin endocrine. Endocrine, I think, scares a lot of people. I don't think that it's that difficult. I think that it becomes difficult for people because the endocrine system is very abstract. You can see the glands, but what does all the action is hormones. You can't see. You know, you can see blood, you can see the lungs, and you can measure the ventilator and all that. But endocrine, it's kind of abstract, and people have a hard time with it because of that, I think. But the endocrine system is, I don't think, too complicated because the hormones have an action. You have to know the action. If there's too much of it, there's symptoms. If there's not enough of that hormone, there's symptoms. And that's the gist of it, if you ask me. So here are some definitions that you looked up, and we'll go through all of these. You've learned about steroids in the past. Now steroids become even more important. So if you ever wanted to know anything about steroids, or if you thought that you knew enough, you'll learn more about steroids now. But that'll come when we talk about adrenal disorders. Anytime you see something that says U before it, that means normal, right? So when we're talking about a person that has hyper or hypothyroidism, we try to get them to a euthyroid state with medications to lower thyroid hormone or to increase it. So anyhow, definitions. And we're not looking. So I think this takes you all the way back to A&P2, you began your A&P2 lecture with endocrine. And but just remember that there are different glands that secrete hormones, hormones that cause other glands to do things and secrete more hormones, which usually we think about the pituitary doing a lot of action to cause other glands to do other things. So lots of glands, and like I said, they regulate growth, reproduction, fluid electrolytes, things like that. All right. So I've already said this, but endocrine disorders, I think, are not extremely complicated because if you know one, you know the other. It's just opposite. Hypothyroidism is the opposite of hyperthyroidism. So you have to know which is too much and which is too little. Like I said, the pituitary gland is also called the hypophysis. It's called the master gland. And this gland right here near the brainstem, way inside of the head there, produces 6 hormones. Remember that 5 of those are trophic. Understand what trophic means. Trophic means that it acts on another gland. I added that little thing in there last night for you. 2 sections of the hypophysis, the adeno and the neurohypophysis. It's easier to remember anterior and posterior pituitary. Okay. So just remember anterior and posterior. I'm not going to ask you, the neurohypophysis is the anterior or the posterior, because you took A&P and had questions like that, right? So just know which they secrete. So the anterior pituitary does most of the work. It secretes these hormones. And as you see, the trophic hormones are hormones that work on other glands. So the adrenocorticotrophic hormone, also called ACTH, acts on the adrenal gland. It stimulates the adrenal gland to release steroids and other things. So as you see, all of these act on other glands, but the growth hormone is a non-trophic hormone, meaning that it works on tissues. You see how it's different? So the anterior pituitary is usually much busier than the posterior pituitary. I think there's a slide. So growth hormone. We don't talk much about this, but it's the growth hormone. So it stimulates the growth of the bones and muscles, also some regulation of organ function. So I'm not going to read this to you, but remember the epiphyseal plates and the long bones. The growth hormone is released by the anterior pituitary to stimulate those growth plates to produce more bone tissue, and therefore a person grows. So the growth hormone affects the epiphyseal plates, causes bone and muscle growth. It also has to do with the regulation of glucose in the blood. That's all I need to know about that. All right. Adrenocorticotrophic hormone, like I said, it stimulates the adrenal gland to produce steroids. Hydrocortisone, aldosterone, other steroids. TSH is a big one. The TSH, the thyroid stimulating hormone, stimulates the thyroid gland. And remember that thyroid hormone is referred to as T3 and T4. Thyroid stimulating hormone is different than thyroid hormone. Thyroid hormone is T3 and T4. Also has to do with calcitonin and the calcium exchange between the blood and the bones. You need iodine in order to create T3 and T4. FSH, just know what it does. We don't talk about any disorders here that affect the FSH. We talked about that in OB. Also, luteinizing hormone has to do with reproduction and things like that. Just know the definition. We're not going to talk about any disorders that affect the alterations in luteinizing hormone. So that was the anterior pituitary. So the posterior pituitary secretes ADH and oxytocin. The one that we talk about most in this course is ADH. So you've already been through this before, DI and SIADH. Antidiuretic hormone is just what it is. It causes antidiuresis, causes retention of water, and also some electrolyte changes. Oxytocin, you learned about that in OB. Just know what it does. So that was the review of your hormones. So make sure that you understand what these hormones that are released from the pituitary gland do. We don't have to know a whole lot about disorders of growth hormone, but when you think about it, you think about dwarfism and gigantism. Dwarfism is undersecretion of growth hormone, and gigantism is oversecretion of growth hormone. But you also want to compare gigantism with acromegaly. In gigantism, there is extra release of growth hormone before the closure of the epiphyseal plates. This means that the person is large, but fairly proportionate, and not a lot of deformities. But in acromegaly, the growth hormone is secreted maybe before and after the closure of the epiphyseal plates. So this causes more symptoms and manifestations because the bones become misshapen. The person has physical deformities in acromegaly. Understand these signs and symptoms of acromegaly. Usually the person with this disorder has lots of cardiac complications.
Because it doesn't affect the heart size, just the rest of your body?
Well, it can. The body becomes very large, and the heart has a big job. So they have congestive heart failure sometimes because it has to work so hard to get that blood around. Yeah. But the growth hormone also works on muscle, so it can hypertrophy because of that too. All right. So I think your textbook has some pictures of people with acromegaly, so you can see the wide face. They have a very characteristics. Think about Lurch from Addams Family. He had acromegaly. All right. The posterior pituitary, we're going to focus on diabetes insipidus and SIADH. So diabetes insipidus, not enough ADH. SIADH is the opposite to each other. All right. This is a low-level knowledge-based question, right? And I just told you the answer to it. Remember, know the difference between a trophic and a non-trophic hormone. So the answer would be bones, right? All right. What's next? So you learned about diabetes insipidus, but I think when you learn a disorder over and over again in the course, you learn more details about it each time. So here we're going to break it down between neurogenic or central diabetes insipidus, nephrogenic, and psychogenic. Maybe you haven't heard of all these before. Good, because I don't want to teach you something twice. All right. Neurogenic is the diabetes insipidus that we normally think about when the person has had some sort of maybe a head trauma there's damage to the pituitary gland. Nephrogenic is where the problem lies within the kidneys. Neurogenic, think neurogenic, the brain, the problem was within the brain. Nephrogenic, the problem is within the kidneys. So the kidneys are not sensitive to ADH. Does it mean that we have insufficient ADH? It just means that our kidneys are not responsive to it. Psychogenic is fairly uncommon, but this is sometimes seen in people with mental health problems. Sometimes persons with schizophrenia or paranoid schizophrenia, they will drink excessive amounts of water as a cleansing ritual, and they can put themselves into a psychogenic diabetes insipidus. They are having lots of urination simply because they're drinking a lot of water, which can be dangerous because of sodium. So for some reason, you have damage to the pituitary gland. In our lectures, you would think about a head trauma. That's probably one of the main causes of diabetes insipidus that you've learned about. We see it very frequently in patients that have damage to the brain. So that's why you're frequently assessing urinary output in your patients with a head injury. So with diabetes insipidus, remember that you have large amounts of clear, dilute urine. Low urine-specific gravity, right? It's like water when it comes out, very diluted. The person's thirst mechanism will kick in because effectively they become fluid volume deficit because they're excreting all of their volume. Remember, it only takes about 2 to 5% of your fluid volume to be lost until your thirst mechanism kicks in. So it's a very sensitive system. The person can become dehydrated, hypernatremic, right, and hyperosmolarity. Vivian asked about osmolarity. So you've seen osmolality. What's the difference? I don't really care if you know the differences between those two terms. I might sometimes use them interchangeably. Just think about osmolarity as a concentration of the blood. So if you're excreting lots of volume and you're getting all the water off of the blood, it's going to become hyperconcentrated, right? So the blood becomes concentrated. It can become very severe, lots of fluid volume loss, and the person could have shock, right? They would become hypovolemic shock, right?
Did you say it was about the amount it takes for your thirst?
As low as like 2%. Yep. Just 2% of volume loss. So polydipsia, polyuria, right? Lots of drinking, lots of urination, low urine-specific gravity because it's diluted. Dehydration, high sodium. All right? I think that you know most of that pretty well. These are your levels that you should know. Really, the urine-specific gravity is the only thing that I'll hold you to. I will tell you what, if I'm talking about osmolarity or osmolality, I'll tell you if it's high or low. So your antidiuretic hormone will be low, right? Unless it's nephrogenic. But we normally don't measure the antidiuretic hormone level. So we have to give this person fluid volume replacement, right? That's our priority to prevent hypovolemic shock. Usually we'll do this with isotonic solutions like lactated ringers, normal saline, D5 half normal saline, something like that. But we can use hypotonic solutions to help with more fluid volume replacement. So we know that we have a deficient antidiuretic hormone here, especially for neurogenic or central diabetes insipidus. And you need to know all about those antidiuretic hormone replacement therapies. They're all basically the same, but they're given differently. When I think about DDAVP, I know that it can be given nasally as well. They're a little bit different, but they have the same action. Right? Molecularly, they're a little different, but they're going to work the same on the kidneys. think there's another slide. Yeah. It's important for us nurses to know when medications have been effective or not, right? So know when DDAVP, Tressin, desmopressin, whatever, has been effective. So obviously that would be a decrease in urinary output and decreased thirst. You would also maybe see signs of a euvolemic state or decreased signs of hypovolemia. That would tell you that the medication is working as well. But really, what's the number one thing that's going to tell us that this is working is what? Urinary output. The medication is usually contraindicated in pregnancy because it can cause uterine contractions and can cause a spontaneous abortion. So that would be used very cautiously, risk-benefit ratio, with this. Why would we avoid alcohol? No, alcohol is a diuretic. You can have cardiovascular manifestations from this medication. For chest pains, the nasal spray can be very irritating to the nasal mucosa. And anytime a medication does something, you always realize that it can do too much of that. So just like with the beta blocker, if it's doing too much, the patient's hypotensive and bradycardic, right? So if this person is having an exaggerated response or has too much medication, so they would have signs of fluid volume excess, right? They're holding on to too much fluid now. You're giving them too much antidiuretic hormone. All right? Remember that weight is a very good indicator of fluid volume status. It is actually better than CDP, because CDP would just follow trends. One CDP measurement doesn't tell us anything. It's like one cardiac output measurement doesn't tell us anything. One blood pressure measurement, right, it's a trend. But weight, daily weights is important. And you remember that 1 liter is 1 kilogram, right? This is interesting to me that these medications can be used to treat diabetes insipidus. Remember you learned about these when you learned about diabetes. Sulfonyl, I can't say the name, diabetes, right? And this has, it causes ADH to work better. And this means drug of choice. All right. SIADH, syndrome of inappropriate ADH. This is often caused because there's a tumor on the pituitary gland that secretes ADH. Remember that tumors often secrete hormones that they shouldn't. Again, if you have a head injury, you can have SIADH. Usually we see diabetes insipidus though. So, DI is low ADH, SIADH is high ADH. So for some reason we have alteration in the ADH. The ADH is released even though the person has a normal osmolarity. So if the blood is concentrated, right, what would happen? So if your blood is normally, if it was hyperconcentrated, you needed more fluid, what would happen? ADH would be released, right? To hold on to more fluid. But this mechanism, this negative feedback mechanism doesn't work. What happens is you have the fluid retention here, and the fluid shifts into the cells, and when the cells get too full, they can become damaged. So this is just the opposite, these manifestations. So you have decreased urinary output, increased urinary specific gravity, right? And I think I made you a nice chart on it. Here you would have hyponatremia, and this is a dilutional effect, right? Let's see, I said all that. So these are signs of fluid volume excess. Headache, mental status changes, listlessness, things like that. Weight gain as opposed to weight loss, and hyponatremia. So remember those signs of hyper and hyponatremia. Take yourselves back to foundations. Remember all those signs of hyper and hyponatremia. Seizures is a big one. So in the person with DI, we need to replace fluid volume. Right here, we need to get rid of it. So we were going to give them maybe hypertonic saline. Remember, how does hypertonic saline work? It helps pull fluid into the vascular space, so therefore it can be excreted. But we have too much ADH, so it's not going to let the body excrete it, even if we do pull it intravascular. So what do? We give them Lasix. We give them a diuretic so that they will hopefully urinate it off. This is one of those medications, declamycin, that we just discovered that there's a side effect that causes diuresis. This can be used. This person will probably be thirsty and want fluid, but we have to put them on fluid restriction. In the heart, the atria, when they become stretched, this tells the pituitary gland that we have plenty of fluid volume, right? So we want to exaggerate that response by we can lay them flat, increase venous return to the heart, help those atria stretch out, and hopefully tell the pituitary gland to slow down producing the antidiuretic hormone, right? And I think, yeah, it's baroreceptors that are in there. So they're also in the carotid arteries. Remember that? The baroreceptors sense pressure. So the person will be thirsty, but we want to tell them that they can't have fluid to perform nursing actions that will moisten the mouth and maybe a few ice tips here and there, but they will be on a very strict fluid restriction. Weight is a big deal, especially with SIADH and DI. The bone structure refers to acromegaly, dwarfism, gigantism. Fluid and electrolyte imbalances are quite important to understand what's going to be happening in these disorders, how the patient's osmolality changes, how the electrolytes change, specifically sodium. What's next? You don't have to go back and memorize normal growth and development or anything like that. But, understand, changes in weight are important, and understand how to maybe identify a person that has a growth disorder, and it's very easy to objectively assess. I'm not going to ask you, like a person greater than 7 feet 2 inches has, it depends. It depends on the patient. Some people are just tall, but some people actually have those disorders. So obviously it's not your responsibility to decide, right? But these are just general things that we would teach, like iodine has to do with the thyroid gland and the production of thyroid hormone. We'll talk about that. I thought that this was interesting that we have lots of changes or alterations in the response to these things in older people. So they have decreased growth hormone but increased ADH. So they will have more of a risk of delusional hyponatremia here because older people just produce more antidiuretic hormone. Right? So know these changes or these alterations in older people. They overall, because they produce higher ADH, they have a higher risk of developing the complication of SIADH. If they were to fall and hit their head, they have a higher risk of having that complication.
Mr. Jackson, you think that has something to do with their thirst receptors?
Possibly, they have a decreased, like it says, response to thirst, so they
Body's
have
having
a
coping
higher
with it.
chance of becoming dehydrated. But yeah, it just in my mind, I just think the body is wearing out, and it's not as sensitive anymore. So therefore, the body increases the production of ADH to decrease the person's risk of fluid body nephrosis. All right. So, if the pituitary gland gives such a problem, they can take it out. All right, this is called a hypophysectomy. Specifically, if there's a tumor of the pituitary gland, know that there's the transfrontal and the subcranial approaches. This would be the oronasal or transsphenoidal approach. This is pretty common. They go through the nasal cavity, and then see the pituitary gland is actually pretty close there at the top of the nasal cavity. This is an incision here. In this picture, they went through the nose, but they can also go through the upper lip and through there. I'm not sure why they would choose to do that, because there's already an opening in the nose, so I don't know why they would choose to do this oronasal route. Most of this is going to be focused on the oral nasal route because we would teach them to not strain, blow your nose, because it can dislodge the dressing after this procedure. There's a risk of CSF leak and increased intracranial pressure after this procedure. It is basically a brain surgery. If they've had the approach where the incision is made in the upper gums, under the lip, teach them not to brush their teeth. All right? So it's not that they can't do mouth care. They would do mouthwashes, foam sponges, things like that, but not a hard bristle toothbrush because of that incision. And of course, the head of the bed decreases ICP, right? So if we remove it, we have a risk of what? Diabetes insipidus, right? Big risk for infection because we've gone into a sterile area of the brain, and the nasal cavity and mouth is a very dirty place. If there's CSF leak, we would look for rhinorrhea. You will see clear drainage. Rhinorrhea just means a runny nose, but if you have clear fluid coming from the nose after this procedure, it's cause for concern. It might be CSF. Right. That was pretty boring, right? The thyroid is going to be basically your meat and potatoes of endocrine. This is the thyroid alterations are by far the most common in the population. You're going to have and have had tons of patients with thyroid disorders. So thyroid is very important. But just remember the anatomy of the thyroid and what it does. So the thyroid gland produces what? Thyroid hormone, which is T3 and T4. The pituitary gland releases thyroid stimulating hormone. I'm not going to read all this to you, but the thyroid hormone, the biggest responsibility of it is to control metabolism. So the thyroid gland is told to produce thyroid hormone or to slow the production of thyroid hormone by the pituitary gland. The pituitary gland will either secrete thyroid-stimulating hormone or not secrete thyroid-stimulating hormone, or increase or decrease that based on the amount of T3 and T4 already in the blood. This is called the negative feedback mechanism. It's when two glands talk to each other. So if you have an elevated T3 or T4 in the blood, what is going to happen? It's going to tell the pituitary gland, we don't need any TSH, we've got enough T4. So don't tell the thyroid to produce more. With your thyroid disorders, often you have a disrupted negative feedback mechanism. They're not communicating properly. It's important to understand the difference between thyroid stimulating and thyroid hormone. And these disorders that we'll talk about, they will be completely opposite, and sometimes they will confuse you, and you'll think that one's up and one's down, but it's the opposite. Okay? So just understand the function of those two hormones. The thyroid hormones that we mostly think about and talk about are T3 and T4. Your blood has more T4 than T3, but T3 is more potent. T4 hangs around longer. T3 is actually the active thyroid hormone because T4 is converted into it after it gets into the body. It also releases thyroid calcitonin, which we don't really talk about much. But it has to do with the movement of calcium back and forth between the blood and the bone. So to diagnose thyroid function or abnormalities in it, the most sensitive thing that we can do is just measure a TSH. Usually, when you go to your doctor for your yearly exam, they're going to measure your TSH level, especially if you're a female over the age of 30. You're going to get a TSH. There's also, we can do a thyroid releasing or thyrotropin releasing hormone test, and that is injected, and we can see if the TSH is working properly. So the radioactive iodine uptake, this is simply to see if its iodine is radioactive, and the thyroid gland is going to absorb iodine so that it can produce T3 and T4. Remember, you have to have iodine to produce T3 and T4. So we'll see if the thyroid gland is properly absorbing iodine, and we can visualize that because we've made the iodine radioactive, and it can be picked up on a scan in nuclear medicine. The thyroid scan is basically the same thing, but iodine isn't used, and we're just looking to see, we're just visualizing the thyroid gland to see if it's enlarged, if there's tumors or anything like that. So TSH and T3 and T4. We also measure T3 and T4. T4 is measured in two ways. There's T4 and then free T4. Free T4 basically is the T4 that can be used. Just regular T4 is already bound to protein. So if it's bound to protein, it's already been used, right? So free T4 tells us how much usable T4 is available. T3 is not routinely measured to help diagnose, but it is measured to see if we have enough thyroid replacement hormone like Synthroid. Because Synthroid is synthetic T3. This is a little complicated, the thyroxine binding globulin. But it helps to diagnose more specifically the problem. You don't need to know the procedure with this. Anything that can increase or decrease T3, T4, or TSH falsely should be avoided before measuring this, right? So the person shouldn't go out and have a huge seafood, like crab and fish and shrimp the night before they go in for the thyroid function test, because it can be altered, because it's iodine. Aspirin, steroids, any hormones should be avoided for at least a week. All right? Hyperthyroid. We're so rounded today, aren't we?
This is riveting.
It is. So hyperthyroidism, think of this as an overactive thyroid. The number one cause of of hyperthyroidism is Graves' disease. Graves' disease is autoimmune. So for some reason, there's an autoimmune problem, and it is causing the thyroid gland to secrete too much thyroid hormone. Or it could be a goiter on the thyroid gland, growths on the thyroid gland that are causing increased production of thyroid hormone. Women are by far more affected by thyroid disorders than men. So for some reason we have an increase in circulation of thyroid hormone. Remember that as T3 and T4. Hyperthyroidism is hyperthyroid. It's too much thyroid hormone. The functions of the thyroid hormones are to increase metabolism. Heightened sympathetic nervous system. What does that mean? Yeah, they're always in a stress response. Right? Tachycardic, hypertensive, nervous, anxious, increased metabolic rate, sweaty. Right. Yes. Heightened sensitivity to catecholamines. Catecholamines are those things that we've already talked about. Norepinephrine, epinephrine, dopamine. Those are catecholamines. So just know that those things are synonymous. So when I say catecholamines, I'm referring to all of those vasopressors. Right? Because, of course, the body naturally releases those. And you mentioned some of the signs of hyperthyroidism. You can see the picture of this lady here. She has fairly large eyes, but here you can really see her large thyroid. Usually exophthalmos is seen with Graves, and exophthalmos is bulging eyes. The eyes are set forward in the socket, and it's caused because there's edema and extra fat tissue behind the eye that is formed because of increased thyroid hormone, and the eyes are pushed forward. Once a person develops exophthalmos, it doesn't resolve. So even if we get them in a euthyroid state, they're always going to have that degree of exophthalmos. So all of these signs and symptoms are manifestations of increased thyroid hormone, and often these just go along with excitability, increased sympathetic nervous system, hypertension. AFib is by far the most common dysrhythmia in hyperthyroidism. We think about the person with hyperthyroid looking like this. Thin, nervous, sweaty, hypertensive, flushed. But that's not always the case. A person with hyperthyroid might look very normal and might be overweight. It's like a person with hypothyroid might be skinny. This is just the classic person. All right? So with hyperthyroidism, the TSH level will be low. Okay, thyroid stimulating hormone is low. T3 and T4 is elevated, right? That's the thyroid hormone. So realize that what goes along with these disorders, hyperthyroidism, like of course that's high, right, is the thyroid hormone. The T3 and the T4 have the effects. The TSH controls the release of the thyroid hormone. Don't let it confuse you. So because we have elevated T3 and T4, it's telling the pituitary gland slow down the production of TSH, right? But it doesn't communicate. So even though we have a low TSH, the thyroid is still kicking out lots of T3 and T4. The autoantibodies relate to Graves' disease, which, like I said, is the number one cause of hyperthyroid. We talked about the physical exam, how this person may look, the things that you will assess. We can give medications that are fairly effective to decrease the production of thyroid hormone. So there are anti-thyroid medications. Tapazole is the most common. So this inhibits the production of thyroid hormone by blocking the action of iodine. Right. So iodine is a precursor to thyroid hormone. Of course, side effects of this, you would mostly think about signs of hypothyroidism, right? Especially if the person gets too much or has an exaggerated response to it, you can term them hypothyroid. It's important to see here, it decreases the production of thyroid hormone, but it doesn't block the action of thyroid hormone if it is produced or has already been produced. So this doesn't act in the periphery. It doesn't work in the tissues to block the action of it. It simply stops the production of it. Okay. Does that make sense? They will closely monitor TSH, T3, and T4 while on this medication, of course, and it interacts with warfarin. So it decreases the function of warfarin. Remember that warfarin Coumadin interacts with lots of medications. And this is one of them. So the patient may have to have an increased dose of warfarin Coumadin when on Tapazole. It decreases the function of it. Give it with food, same time, every day. Remember, the category D means that there have been studies to show that there's damage to the fetus. So this shouldn't be used in pregnancies. This person should avoid becoming pregnant if on Tapazole. Another one is PTU. It also works very similar. It decreases the production of thyroid hormone. And it also inhibits T4 from turning into T3. Remember that T3 is actually the active thyroid hormone. T4 is a precursor to T3. So it helps the T4 not turn into T3. Same side effect as Tapazole, but also lupus-like symptoms, which you don't know yet, so I'm not going to ask you about lupus-like symptoms. Well, no, it'll be on the same test, won't it? Yep. So, yeah, it might. Because this is immunology. Good. So potassium iodide, it's abbreviated SSKI, but this decreases the vascularity of the gland, which means basically if we're not getting flow to the gland, the action of it will be decreased. So if it's not being perfused, it's going to produce less T3 or T4. All right? Dairy decreases the effectiveness of it. It is an oral solution, so give with lots and lots of water. We can give beta blockers to these patients, but the beta blocker isn't necessarily going to do anything about the production of thyroid hormone. This one it's a symptomatic treatment. So remember that beta blockers work by binding to the beta receptor, so that therefore the catecholamines cannot bind to those beta receptors and work. I don't need to talk much about that. You guys are good with beta blockers. Radioactive iodine. This is a big treatment for Graves. The iodine is, I think of it as being laced with a certain type of radioactive material that is toxic to the thyroid gland. So, of course, if you give a person iodine, where's it going to go? Straight to the thyroid. It's going to suck it up. But think of this as being laced with a radioactive substance that is damaging to the thyroid gland. So it's going to be absorbed because it's iodine, but it's toxic to the thyroid gland. So it destroys thyroid tissue and hopefully decreases the production of thyroid hormone. Again, contraindicated in pregnancy. You understand how that works?
pretty serious treatment method.
Yeah,
That'd be the last, right?
Often what happens here is that we will turn the patient into a hypothyroid state, but it's easier to treat. But the last treatment, which is not used often, is removal of the thyroid gland. Because we can kill it pretty easily with radioactive iodine. Sometimes it will be part of this one.
Is the radioactive iodine, is that permanent damage or is that just
Permanent, yeah. Normally we don't give something to damage something, right? But here we do. Like I said, thyroidectomy is not a common procedure to be used for this, but it can be done if all of the treatments are ineffective. We will give medications to hopefully decrease the size of the thyroid gland before, so we can kind of shrink it up before get it hypofused, so that before we take it out. It decreases the risk of a thyroid storm during this procedure. So, I think, isn't there a slide on thyroid storm? I don't know about it. No? Okay. That's it. Okay. So just know that during this procedure, you have a risk of a thyroid gland. Anytime you get cutting into the thyroid gland, it can release extra thyroid hormone, and the patient will have a very exaggerated response to that, which can be very dangerous. So know the post-op care related to a thyroidectomy. It's comfort for the neck, the head of the bed up, and on pillows, which seems pretty silly. Most patients will have this anyway. But it's comfort of the neck, because the patient will be sore post-op. Realize that the patient is having surgery on their neck. A lot of stuff going on in the neck, right? A lot of perfusion, and your airway is there. So realize that after surgery, the patient is at risk for edema related to it, so therefore that edema can be close to the airway. So close monitoring of this patient's respiratory status. Anytime a person has had a neck surgery, a trach tray should be very available. Usually what we do is we just go ahead and order it and keep it in the room. In case the patient has any problems, they can put a trach in right there at the bedside. The person who has hyperthyroidism, certainly if we take out their thyroid gland, they are going to be hypothyroid now. But that person who is hyperthyroid required increased calories. They had a very high metabolic rate. They're used to eating a certain way, and now they're going to not need near as many calories. So lots of education with diet. Like I said, the number one complication endocrine-wise is the patient will probably have hypothyroidism afterwards, but again, it's easier to treat. We'll talk about parathyroid disorders, but the parathyroid glands are attached to the thyroid gland, so there's a risk that these can be related to the patient with hypoparathyroidism as well, which is related to the hypocalcemia and TED. Those two go together. Respiratory, vocal, all the next stuff, and the thyroid toxicosis or the thyroid storm. That's the extra release of thyroid hormone, and of course, if you just dump a bunch of thyroid hormone into the patient's bloodstream, they're going to have lots of symptoms, right? So it's just those signs of hyperthyroidism that they're exaggerated. So hyperthermia, very high temperatures, very high heart rate, right? They'll be very agitated, hypertensive, very dangerous. Know the action of aspirin. Aspirin increases the production or potentiates the action of thyroid hormone. I think on page 499 there's something that talks about a thyroid storm. So it's a good place for reference. Hyperthyroidism, nursing diagnoses. See, I type a lot here. Let's see, I'm going to read it to you when it says figure it out. Decreased cardiac output, And this is probably because of the dysrhythmias. Remember, the number one dysrhythmia with hyperthyroid is what? What else? And remember that even though a person with hypertension, they can also have decreased cardiac output because you have increased catecholamine-like symptoms, right? So you have maybe vasoconstriction, and the afterload is really high, so the blood is not being perfused, right? So that person would have decreased cardiac output. This is related to the exophthalmos, the vision changes, the dryness of the eye. Sometimes the exophthalmos becomes so severe that the eyelids will not close and go over the eyeball, so they physically have to put the eye down. So lots of dryness of the eye. Know those nursing interventions that we do to help decrease corneal abrasions with exophthalmos and eye discomfort with the exophthalmos. We talk about the hypermetabolic state. If you understand hyperthyroidism, you can understand hypothyroidism because it's just the opposite. Sometimes it's called myxedema, and in babies, in young babies, it's called cretinism. Again, women are more affected by endocrine problems. What else? Know the difference between primary and secondary hypothyroidism. Primary would maybe be that treatment for hyperthyroidism, inflammation of the thyroid gland, not enough iodine. And the secondary is a pituitary problem, or it's just simply that the body or the tissue doesn't respond to thyroid hormone. So for some reason, the thyroid gland is not producing enough T3 and T4. So when the blood has a low amount of T3 and T4, thyroid hormone, it's going to tell the pituitary gland we need more thyroid hormone, so give us more TSH. So in this person, you will have an elevated TSH level, but low thyroid hormone levels. Often the thyroid gland can keep up just enough to keep the patient asymptomatic. And this is that period of compensation, so subclinical hypothyroidism. The labs with this would show that the T3 and T4 are normal, but the TSH is a little bit elevated. So it's able to compensate for just enough time, but eventually that won't be possible. Why would the thyroid gland become hypertrophied or overgrown?
It's getting more TSH.
It's getting more TSH. Yep. It's saying we don't have enough, so get bigger and make more, but it can't. Sometimes it's difficult to diagnose hypothyroidism. It's a very common problem for old women. Lots of old ladies have hypothyroidism. Sorry, that was fun. The person with hyperthyroid is heat intolerant. The person with hypothyroid is cold intolerant. It's basically the opposite. Most of these manifestations are opposite. I don't want to read all this to you, but the person with hypothyroidism has a big risk of dyslipidemia. So high LDLs, low HDLs, so they have a big risk of cardiovascular problems. You remember that hyperthyroid, the person may have a goiter, but also in hypothyroidism. And this is because the thyroid gland has become enlarged. It hopes to produce more T3 and T4, but it doesn't. It's the same assessment. We do the same labs for this patient that may have hypothyroidism, but the studies will come back opposite. The TSH will be elevated, the T3, T4 will be low. Remember, the hypo is low, and that hypothyroid matches the T3, T4. big risk for cardiovascular problems. So if we don't have enough thyroid hormone, how do we treat it? Give them some thyroid hormone, right? The number one way that we treat hypothyroidism is with Synthroid. Just like with Tapazole and all those other medications that decrease the production of T3, T4, you would have signs of hypo, but if we give thyroid hormones, we don't have signs of hyper. So this person may have too much thyroid hormone with Synthroid, and they can have manifestations of hyperthyroidism. It's important to teach that patient to report those signs of hyper, because that means they probably have too much Synthroid on board. With Tapazole, remember it affected Coumadin warfarin by making it not active enough. Synthroid will potentiate the action of warfarin, and they may need a lower dose. It's just the opposite. An effective levothyroxine, Synthroid, or hyperthyroidism is weight loss, increased metabolic rate, but realize that the person should not be treated for being overweight by just giving Synthroid. Patients ask for this, okay? Because they know the side effects of it. But it is dangerous because of the cardiovascular problems that go along with that medication. And it's not well absorbed, so give on an empty stomach. Levothyroxine versus Synthroid. We talked about this with Coumadin and warfarin, right? That difference in bioavailability. So a normal T3 level is a narrow range. So remember that brand name and generic have a difference in bioavailability. Usually it's not enough to make any difference. But it makes a difference in this medication because the problem that it treats, that T3, that low T3, normal T3 has a very narrow therapeutic range. So any small changes in the dose can throw the patient either with too much or too little. So if the patient is started on levothyroxine, which of course is generic, they should stay on it. Synthroid, they should stay on it. It's not to say that the patient cannot change from generic to trade, but it would be as if we were restarting therapy. All right, we've got to go back to square one, so we're going to start it. And maybe if they went from levothyroxine to Synthroid, they might decrease the dose a little bit because the brand name stuff is usually more potent. I think this says how do you know the treatment is effective, right? And what labs you will monitor. Closely monitor T3. Yep. They're going to measure both of them, but T3 is the potent, more active thyroid hormone. Big risk of constipation, so know those interventions that we do as nurses to decrease the patient's risk of constipation. Lots of fluids, high fiber, bulk forming, and stool softeners. Sedatives and narcotics slow, right? The digestive system, increasing the risk of constipation. The person with hypothyroidism has often fragile skin, so be careful with their skin, especially if they have actual myxedema, which is this really serious complication. Understand what empty stomach means, right? Because if I just said, I don't know, true or false, Synthroid is taken on an empty stomach. True. Well, but you have to know what that means, all right? So basically, you tell the person you can have it 1 hour before or 2 hours after meals, because it takes the stomach about 2 hours to empty. And we want to give it an hour to be absorbed before we put anything on the stomach. So be able to apply that concept. Why would we limit iodine in this patient?
Will potentiate the action.
Right, it'll potentiate the action. and also potentiates the action of digoxin. So the thyroid toxicosis or thyroid storm is a big complication of hyperthyroid. This is your big complication of hypothyroidism, myxedema coma. So some sort of stressor like infection or surgery can cause the patient to go into this state, and it is severely, severely low thyroid hormone. The treatment of this is what? Thyroid hormone. We gotta give them some thyroid hormone. We can also give IV T3. Cretinism is basically hypothyroidism in babies. Every child that is born gets a newborn screen, which is assessed in the newborn screen. But if hypothyroidism is not corrected in the infant quickly, they will have signs, usually of mental retardation. So this is a very big deal in pediatrics. The hallmark sign of cretinism is weight loss and the child not eating properly. They don't latch, they don't tolerate food, they're not gaining weight, they're restless, not a lot of energy, lots of sleeping. Babies sleep a lot anyway, but excessive leverage. And just an overall small baby. I don't know why this isn't discussed in peds. I asked Ms. Makoto, and she said that it wasn't. So, there you go. Peds and adult. Alright? Again, T3, T4, TSH. We can look at the size of the child to see if they're proportionate. And like I said, if we find this early, hopefully, the majority of the time the newborn screen is going to detect this. But sometimes it takes a long time to get the results of the newborn screen. It has to be, maybe the first time it was done there wasn't enough blood or it was inconclusive. Sometimes, in my practice, I'll take 2-3 months and we're still fighting with this newborn screen because we haven't gotten a proper result back. But the majority of the time it comes back just fine and that newborn screen will pick it up. But the goal is to figure it out within a month and then get the child on some Synthroid. This is interesting that the younger a person is, the more Synthroid they need. They have a higher metabolic demand. Younger people, right? Babies and children have a higher metabolic rate. So they need more Synthroid. Adults start at just about a tenth of the dose as a child. It's not well. You want to stop here? Yeah. Is it?
It is, yeah. One more screen and then we'll be happy.
Okay. We'll find it. But it takes me a long time to get through hypopara. It takes longer to get through that. I know that this stuff is not extremely exciting, but don't get too bored studying it because it is important, especially thyroid. Thyroid is by far the most common complication in our population, hyperthyroid. You have any questions? We'll probably have a little bit of extra time, but I think that I have lots of practice questions on endocrine that we'll do next Tuesday. So,
Thursday night.
there's 3 endocrine days, right?
So the Tuesday after spring break.
Yeah.
The next Tuesday. No questions?
Who did you do the lectures on endocrine last semester? Okay. So, would you be willing to throw up your 3rd endocrine lecture over spring break?
When is the test? Oh, I can. If you want to spend your spring break studying adrenal disorders.
Yeah, we will.
I don't
anyway.
want to, but I probably should.
Yeah, you know, we probably will anyway. It was really helpful for the last.
At this point, we're
Yeah.
having a life.
Nobody's going out of town for spring break?
Yeah, I am.
Today's spring break.
At 8 hours, I'm sitting in the car. Put some headphones in.
Yeah, that's just
Although,
We've had everything today, so.
although that might be dangerous on the road. Listening to different lectures while you're driving here. Nodding off.
Okay, well, apparently there's some snacks up here, so eat them. And Dr. Vieser will be here, might already be here, so she'll be in. So much to us about the R&D.